She went to her doctor 4 times, 4 separate appointments, over 4 years, about the same problem. And every single time, she was told the same thing. This is normal at your age. There isn't much we can do. What she did not know, and what her doctor apparently had not reviewed, is that the research on her specific condition has been conclusive for over a decade. A treatment existed. It was studied. It had published success rates above 80% in women her age. It was endorsed as first-line care by the leading authority on women's menopausal health in North America. She was never offered it. More than 50% of postmenopausal women experience urinary incontinence. By age 65, that number climbs towards 75%. This is not a niche problem, this is the majority, and the majority have been told the same thing she was told. In this video, I am going to walk through both approaches to postmenopausal bladder leakage, study by study, and show you exactly what the evidence says each one delivers. Option A is what most primary care physicians recommend: pelvic floor exercises, lifestyle changes, and management. I will show you what the clinical literature says about the outcomes of that approach for women whose incontinence is hormonally driven, and what it cannot address. Option B is what the evidence actually supports as first-line care, a category of treatment called genitourinary syndrome of menopause, which has its own clinical name, its own treatment pathway, and its own published outcomes, none of which most women have ever heard. I will also show you a third option, the procedure that exists for women who have moved past conservative management, what its outcomes look like, and why almost no primary care physician will bring it up first. And I will give you the honest reading of this research that argues against the most optimistic interpretation, because this data does not all point in one direction, and you deserve to know that. Subscribe, because the next video might save you years of frustration. Before I go further, I want to be clear about something. Your health decisions belong in a conversation with a qualified physician who knows your complete medical history. What this video can give you is the language to have that conversation more effectively. To understand why this gap exists, you have to understand how postmenopausal pelvic health is, and is not, addressed in a standard primary care appointment. The average primary care visit runs between 12 and 15 minutes. There is no standard screening protocol for urinary incontinence in postmenopausal women. There is no checklist item that prompts a physician to ask about bladder control the way there is for blood pressure or cholesterol. And there is no question in most annual wellness visits that invites the conversation, which means the conversation only happens if the patient raises it. And research on this specific condition consistently shows that fewer than 1 in 4 women with urinary incontinence ever brings it up with a physician at all. Not because they do not have symptoms, because they have already been told, by culture, by assumption, by a previous dismissal, that this is simply what happens after menopause, that it is normal, that there is nothing to be done. The medical system did not create that belief deliberately, but it has sustained it through a clinical framework that categorizes postmenopausal bladder leakage as a structural consequence of aging and vaginal delivery, and treats it with the tools that address structure: pelvic floor exercises, bladder diaries, absorbent products. What that framework does not account for is the hormonal mechanism. After menopause, estrogen levels drop from between 40 and 200 picograms per milliliter to between 5 and 18. That is not a minor fluctuation. That is a near-complete withdrawal of the hormone that maintains the thickness, elasticity, and function of the urethral lining, the bladder wall, and every tissue in the genitourinary tract. When those tissues thin, and they do thin, without estrogen, in virtually every postmenopausal woman, the result is not just dryness. It is a reduction in the structural support that prevents involuntary leakage. It is an increase in urgency. It is a bladder that triggers inappropriately. And it is a condition that does not resolve on its own. The Menopause Society, the leading North American authority on menopausal medicine, has a name for this. It is called genitourinary syndrome of menopause, GSM, and it is not a side note. Research from the Let's Talk Menopause organization, drawing on published prevalence data, estimates that 84% of all women will experience it. 84%. And most of those symptoms do not resolve if left untreated. This is where Carol enters the story. Carol is 63 years old. She taught school for 31 years. She raised 2 children. She has seen the same primary care physician for 18 years, a physician she trusts and who she believes knows her health better than anyone. 3 years ago, Carol went through menopause. Within a year, she started noticing something she did not want to name. She would leak when she sneezed, when she laughed, when she coughed. Small amounts, uncomfortable amounts, enough to make her change her behavior. She stopped going to her Thursday morning fitness class. She started planning around bathrooms. She bought absorbent pads and stopped mentioning the reason to her daughter. And then she did something most women in her situation do not do. She brought it up with her doctor 4 times. Each time the answer was some version of the same thing. This is very common after menopause. Try some Kegel exercises. There are products that can help you manage it. What Carol's doctor did not say, and may not have known to say, is that what Carol was describing has a clinical name, that it has an estrogen-mediated mechanism, that there is a first-line treatment recommended by the world's leading menopause organization, and that if conservative measures were not working, there is a minimally invasive outpatient procedure with an 88% patient satisfaction rate in women Carol's exact age. So let us start with what Carol was told, and what the research says about it. Option A, the standard primary care pathway, centers on behavioral intervention, pelvic floor muscle training, Kegel exercises, bladder diaries, fluid management, lifestyle modification. This is the guidance most women receive, and in some cases it provides meaningful improvement. The evidence for pelvic floor muscle training is real. A 2019 systematic review published in the peer-reviewed literature found that active treatments, including pelvic floor training, are generally more effective than no treatment for urinary incontinence in women. That finding matters. But it comes with a critical limitation that is almost never communicated in a primary care appointment. Pelvic floor exercises address muscle tone. They address the contractile capacity of the muscles that support the urethra and bladder neck. What they do not address is the tissue itself. When estrogen drops after menopause, the urethral lining thins. The bladder wall becomes less flexible. The tissues that are supposed to provide passive structural support without active muscular effort atrophy. You can do Kegel exercises every day for 6 months and build significant pelvic floor strength and still have leakage, because you are training a muscle that is trying to compensate for tissue that the hormonal withdrawal has thinned. This is why the outcomes for behavioral intervention alone in postmenopausal women with hormonally driven incontinence are often partial improvements rather than resolution. The research on behavioral therapy is clear that it is more effective when combined with other interventions. That combination, behavioral plus hormonal, is almost never what primary care delivers first. The other issue with option A is one of access. Pelvic floor physical therapy, the specialized, supervised version of pelvic floor training, has published outcomes that are significantly stronger than self-directed Kegel exercises. A specialized pelvic floor physical therapist can assess whether a patient is actually contracting the correct muscles, can provide biofeedback, and can develop a protocol specific to her pattern of leakage. Most women are never referred to one. If you are watching this and you have been managing incontinence with pads, with Kegels, with avoidance, and it has not resolved, the research suggests you are likely working on the behavioral layer of a condition that also has a hormonal and in some cases a structural component. The question to ask at your next appointment is not, "What else can I try?" The question is, has my incontinence been evaluated as a possible symptom of genitourinary syndrome of menopause? That is a specific clinical term. It changes the conversation. Here is where it gets more important. Because when I look at what the research actually recommends as first-line care for postmenopausal urinary incontinence that is hormonally driven, and then I look at what percentage of eligible women are actually receiving it, the gap is not small. It is not a matter of some physicians offering it and some not. It is a matter of a treatment that has been endorsed by the top authority in menopausal medicine, that has a safety profile the same organization describes as appropriate for long-term use, that is available at almost every gynecology practice in the United States, and that most women have never been offered. That gap has a reason, and it matters that you know what the reason is. Option B starts with a diagnosis that has existed in the clinical literature for over a decade and that most women have never heard. Genitourinary syndrome of menopause, GSM. GSM is the clinical term for the group of symptoms that result from estrogen loss in the genitourinary tract: vaginal dryness, urethral thinning, bladder urgency, increased frequency, leakage, recurrent urinary tract infections. The Menopause Society identifies it as one of the most prevalent and undertreated conditions in postmenopausal women. The first-line treatment the Menopause Society recommends for GSM-related urinary symptoms is low-dose topical vaginal estrogen, not systemic hormone therapy, not the estrogen that raised concerns in the 2002 Women's Health Initiative study. Local, topical, applied directly to the vaginal tissue, absorbed locally, with systemic absorption levels that the Menopause Society states are so low that a progestogen, the counterbalancing hormone that concerns many physicians, is not required. And yet, fewer than 7% of eligible postmenopausal women in the United States are currently receiving it. That is the gap, not a research gap, a delivery gap. For women whose primary symptom is urge incontinence, the sudden, overwhelming need to reach the bathroom, the mechanism is often GSM-driven tissue irritation of the urethral and bladder lining. Topical estrogen addresses that mechanism directly. In women with genuine GSM-driven urgency, the improvement in symptoms with local estrogen can be significant, and it is cumulative over weeks and months of consistent use. For women whose primary symptom is stress incontinence, the leakage that happens when you cough, sneeze, or laugh, the pathway that the evidence supports, when conservative measures have been tried and not resolved the problem, is pelvic floor physical therapy combined, in some cases, with topical estrogen to restore the urethral tissue that the muscles are trying to support. And then there is the third option, the one almost no primary care physician will mention first. The mid-urethral sling procedure is a minimally invasive outpatient surgery that has been the gold standard surgical treatment for stress urinary incontinence for over 25 years. It is performed in under an hour. A small segment of synthetic mesh, 8 centimeters long, 1 centimeter wide, is positioned under the mid-portion of the urethra. One small incision, no external exit wounds. Most women return to sedentary work the same day. The New England Journal of Medicine published a randomized controlled trial in 2022 comparing sling procedures in women across 21 hospitals. Patient-reported success at 15 months, 79%. A separate analysis of 5,200 women aged 55 to 94 who underwent mid-urethral sling surgery, published in the International Urogynecology Journal, found a cure rate of 88.5% in the 55 to 64-year cohort. The long-term reoperation rate, 2.7% at 5 years. That means out of every 100 women who had this procedure, fewer than 3 required an additional procedure within 5 years. This is not a fringe intervention. It has over 300,000 surgeries in the United States documented in a single population-based cohort study. It is covered by Medicare, and it is almost never the first thing a primary care physician offers a woman who says she leaks when she sneezes. Before I give you the action steps, I owe you the honest reading of this research that argues the other way, because other physicians and other sources will use a more cautious interpretation, and you should know that interpretation exists. On topical vaginal estrogen, some physicians remain reluctant to prescribe any form of estrogen to women with a history of estrogen receptor-positive breast cancer, or to women with undiagnosed vaginal bleeding, or to women who are managing other estrogen-sensitive conditions. The Menopause Society's position statement does not exclude these women categorically, but it does note that the decision requires individual clinical assessment. The 7% figure I cited reflects eligible women broadly. Individual eligibility varies, and there are cases where topical estrogen is genuinely not appropriate. On the mid-urethral sling, the 88% cure rate I cited applies to the 55 to 64 age cohort. The same study found that the cure rate in women 75 and older drops to 64%. Age, BMI, and the presence of concurrent conditions all affect outcomes. The procedure is not appropriate for all patients, and the decision to pursue surgical intervention should be made in consultation with a urogynecologist, not a general practitioner. Other sources, including many primary care physicians, will use the first-line conservative management position as the only recommendation, without presenting the hormonal mechanism, the GSM framework, or the surgical pathway. That is not necessarily wrong. It reflects a different threshold for intervention. Now you know both thresholds exist. Here is what most women accept at an appointment about this topic, and what the research says you have the right to ask for instead. What most women accept. This is very common. Try some Kegel exercises. Use pads to manage it. What you can ask instead. Has my incontinence been evaluated as a possible symptom of genitourinary syndrome of menopause? I would like to understand whether a hormonal component is driving my symptoms before we discuss management only. That specific question, using that specific term, signals to your physician that you have done research and you are asking for a clinical framework, not just reassurance. A physician current on the evidence will know exactly what you are referring to. What most women accept. If a physician suggests Kegels and lifestyle changes, they leave it at that. What you can ask instead. Is there a pelvic floor physical therapist you can refer me to? I would like a supervised assessment before I continue with self-directed exercises. Specialized pelvic floor physical therapy, not self-directed Kegels, is what the evidence supports as the effective behavioral intervention. They are not the same thing, and a referral is something you can ask for directly. What most women accept. If conservative management has not worked after months or years, women continue managing with products and avoidance. What you can ask instead. I have been managing this for more than a year and it has not improved. I would like a referral to a urogynecologist to discuss whether I am a candidate for additional options. A urogynecologist, not a general practitioner, is the physician trained to assess the full treatment spectrum for this condition, including the procedural options. The first action you can take before your next appointment is this. Write down exactly how long you have been experiencing symptoms, how frequently they occur, and what makes them worse. That documentation, not a verbal summary in a 12-minute appointment, is what gives a physician enough information to move past the generic reassurance. And before you make any changes to your treatment or seek any procedure, bring these specific questions to a physician who is current on the research. Not every primary care physician has reviewed the Menopause Society's most recent guidelines on genitourinary syndrome of menopause. You now know what to ask for. The best time to have this information was before Carol's first appointment 4 years ago. The second best time is before your next one, and that appointment is coming. Carol did eventually find a urogynecologist. She was evaluated, diagnosed with genitourinary syndrome of menopause, started on topical vaginal estrogen, and referred to a pelvic floor physical therapist. Within 3 months, her symptoms had reduced significantly. She went back to her Thursday fitness class. She told me she had mentioned this problem to her doctor 4 times and been told there was nothing to do. She said she assumed that was true. The medical system gives you the information it has time to deliver in 12 minutes. This channel exists to give you the information the evidence actually supports, in the time it takes to actually explain it. If this video gave you something useful, please share it. I know this is not an easy topic to bring up, but the women in your life who need this information are not going to find it at their next appointment. You can send it to them right now. Subscribe if you want to stay with this, because the next video addresses something that may explain several other symptoms you have been told are just part of aging, and the research has a very different answer.